So our next presenter is Professor Chris Rowe. And Professor Chris Rowe will be talking about ADNet, Neuro Imaging and Biomarkers. Chris is the Director of Molecular Imaging Research at Austin Health in the University of Melbourne. And his other appointments is that he's a nuclear medicine physician and neurologist with over 20 years of experience in dementia research and patient care. He's the Principal Investigator and Director of the Australia Dementia Network, established in late 2018 with funding from the federal government through the NHMRC National Institute of Dementia Research and philanthropic donors. His research focuses on molecular brain imaging of neurodegenerative disease, namely Alzheimer's disease, for better understanding, early and accurate detection, and to facilitate development of early therapeutic interventions. In 2019, Chris was the highly cited researcher for the top 1% for worldwide for neuroscience, and has received international awards for his work, including the US Society of Nuclear Medicine, the Kuhl-Larsen Award for Outstanding Contribution to Brain Imaging, and the Christopher Clark Award for Advancing Human Amyloid Imaging. So thanks, Chris, for doing your presentation on.
Thank you. Good morning. It's my turn to play with the clicker. So here we go. Mine works. So a few conflicts of interest, basically grants from various companies, as well as, of course, government agencies. And let's see, I'm on a few advisory panels as well, including Biogen for improving access to amyloid PET. Prior to what they hope will be marketing of aducanumab in Australia. So I'll first start off talking about the Australian Dementia Network. Now there's the website if you want to know anything more about it. It's Australian Dementia Network, all one big long word. Well, actually, sorry, this is wrong because it should say .org.au. This was our original website, but it's australiandementianetwork.org.au. And as you've just heard, this was a collaboration of leading dementia researchers from around Australia that got together and was successfully funded in a grant from the NHMRC through what was at the time the Boosting Dementia Research Grant. And we got 18 million from there, and we got $2 million from philanthropic sponsors to get together and undertake some major projects that required a national focus and a lot of time and investment. So there are three main initiatives that the Australian Dementia Network is running. One is what is called a clinical quality registry. So we've been developing this and rolling it out. I think there's 50 memory clinics now putting patients into this registry. So anyone that's given a diagnosis of Alzheimer's disease or mild cognitive impairment is put into the registry. They have the option to opt out, but the idea is to collect data on the quality of their diagnostic workup, but more importantly, their journey through life. So this is a diagnosis to death, basically, registry that will monitor what happens to them over the years, benchmark the quality of their care, look at differences in regional care delivery and access to diagnostics and appropriate services, use that information to feed back to the treating clinicians, the local government areas, the state and federal governments, and hopefully will drive an increase in the quality of care nationally. So that's now set up and underway and looking for new clinics to join and new specialist referrers to also start contributing their patients to this registry. The second initiative is the memory clinics, and this is a attempt to standardize or set, I guess, aspirational goals for memory clinics and try and get some standardization of the assessment process and perhaps improve the post-diagnostic care, and also to educate clinicians in areas relevant to the function of memory clinics. We're also using this initiative to start implementing new diagnostics into Australia, particularly the blood diagnostics, which I'll talk about towards the end. The third initiative, the one I'm most involved with, is screening for clinical trials. So we want to increase the rate of involvement of Australians in clinical trials. As you heard from Michael earlier on, there are, I think, 1,400 trials running in the US, but only 117 in Australia, and many of these are inactive. And Australia sometimes gets bypassed from the large trials because of concerns about low recruitment. So we're trying to drive up recruitment, shorten the time required to recruit for trials, and we've been doing this, and I'll go into the details of how we do this. So what we've done is set up screening trial sites around Australia, and we have these sites now in Melbourne, Perth, Brisbane, Sydney, Newcastle and Adelaide. When a patient gets referred to one of these sites, they undergo a thorough neuropsychological assessment. They get an amyloid brain PET scan, they may get a tau PET scan, they get a 3T MRI, ApoE4 genotyping, blood is collected for storage for research, and some of them undergo a lumbar puncture, but that's optional. Now, these patients are referred by clinicians, and the results are sent back to the referring clinician and they're discussed with the patient. We've also worked on improving access to PET tracers for amyloid and tau. So we've now got 5 sites. We've got 3 sites producing in Rowe, Brisbane, Austin Health, and over at Rapid in Perth. It's the Charles Gardner. SAMRI is working on getting their production up, and Liverpool Hospital should be producing these tracers by the end of the year. These are the contact details of the relevant screening sites, although at the moment there's a central referral for web-based referrals to adnet-screening@unimelb.edu.au, but they're distributed out to the state-based coordinators depending on the location of where the patients live. The referring clinician is usually asked to fill in one of these simple forms. They just have to click a few eligibility criteria, which basically are the main criteria for trial suitability. The patients do have to have a mini mental state score of greater than 18 and a suspected diagnosis of Alzheimer's disease. We are getting referrals from public and private specialists. We then do a phone screen, and after that on-site screening, and if they pass all that, which includes some very basic cognitive testing to make sure they do have objective cognitive impairment, they then get the scans and a later detailed cognitive assessment. There's a feedback meeting. The referring clinician is offered the option to give the feedback. The referring clinician certainly gets the results of the investigation. So the incentive for referral is that it improves their diagnostic accuracy for their patient, but it also gives them an offer, some hope to give to the patient that, yes, you've got this diagnosis of mild Alzheimer's disease, and that's pretty catastrophic, but there is some hope with trials. And we make it possible for private clinicians to send their patients to a group that can discuss all the available trials and match the interests of the patient with the particular trials that are currently recruiting. So they may go straight into a trial, which most of the people do if they're suitable and amyloid positive. They may go into a trial-ready cohort for future trials, or they may just be put into a longitudinal cohort study. We are also screening now for preclinical, so asymptomatic. This is particularly for the AHEAD study, which is now recruiting in Australia. We have a volunteer portal on our website. There it is again, australiandementianetwork.org.au. This website collects contact and medical details, including whether they've got existing diagnoses of MCI or dementia. In selected patients, we're mailing them a saliva testing kit for ApoE4 testing. If they We're selecting patients off of this website for in-person assessment. So if they're over 55 and generally don't have any major trial exclusions, and they're either an E4 carrier, high-risk subjective memory complainer, or a first-degree family history of onset of Alzheimer's disease under 75, then we'll call them in, we'll keep them in, and we'll undergo amyloid PET and the full workup. And if they turn out to be amyloid positive and otherwise meet the trial criteria, they'll either be referred to AHEAD or to other studies such as the Arrow Lifestyle Intervention Study. So this is the website. It's just simple questions. It only takes about 2 minutes for a volunteer to fill in. It's got questions about their memory, questions about their diagnosis. If they know their MMSE score or MOCA score, they enter it. Then it just has some basic trial general health questions, some MRI eligibility type questions, and then some indication as to whether they want to go into a clinical drug trial or they're more interested in lifestyle interventions or observational studies online or observational studies on site, and they can select one or all of those options. So at the moment, we have, since beginning of 2019, successfully screened about 500 patients with MCI or mild AD, and most of those have been referred to various trial sites. We have over 2,300 people signed up to our volunteer register. Most of those, unfortunately, are in Melbourne because most of the publicity has been in Melbourne. So we do need to do some more publicity in the other major mainland capitals. It's a good cohort. They're mostly aged over 65 and they've mostly got the risk factors we're looking for. And of those we've approached, 70% have passed the initial clinical screening and been referred to amyloid PET. The amyloid PET positivity rate we're achieving at the moment is about 30%. So in Melbourne, we've now done amyloid PETs on about 35 people that we're screening with a view to the AHEAD study, and our positivity rate's about 30%. We're going to work on that by enriching more for E4, and we're probably going to bring in a blood phosphotal 181 biomarker test as well. The ADNet screening and trials has been successful in bringing trials to Australia that were going to bypass Australia. The Clarity trial was one of them. When ESI were told about ADNet, they changed their mind and included ADNet as a country for that trial. And likewise, it's our track record and the knowledge that ESI have about the AHEAD study and also the academic collaborators in the US that made sure Australia was a significant site for the AHEAD preclinical study. Now I'll talk about neuroimaging. So MRI, well, the MRI is available to most, although there's not a specific Medicare rebate for MRI for dementia. That means you then have to say that you wish to exclude stroke or something else. We know that hippocampal atrophy is an established biomarker for Alzheimer's disease, but it's not that terrific because it's not specific for Alzheimer's disease. In fact, it's even more severely seen in this TDP-43 related condition called late, or what used to be called primary hippocampal sclerosis, seen in the more elderly patients over the age of 80, and it presents with an amnestic dementia very similar to Alzheimer's disease. You also get hippocampal atrophy and frontotemporal dementias. If you find lobar microbleeds, such as you can see here, these little black dots, it does add specificity, so we do include that as part of our routine MRI. But the main use of MRI is to look for the amount of vascular disease present. So small vessel disease can be seen as lacunar infarcts or diffuse white matter hyperintensities. But also dilated perivascular spaces are also associated with that cognitive decline and a probably reflection, another reflection of impaired cerebrovascular function in the brain. I want to talk about FDG PET now because there is going to be a rebate specifically for the diagnosis of Alzheimer's disease available from the 1st of November. That's now been formally announced. Now, as part of this FDG brain PET scan, the scan will have to be analysed by quantitative comparison to a normal database. Otherwise, the scan is going to be available after consultation with a specialist or after the patient's been seen by a specialist, where the result is equivocal, the diagnosis is equivocal, and FDG PET would assist in the differentiation of Alzheimer's disease and is likely to alter the patient management. So this is what those quantitative database comparisons look like. They're a very nice way of displaying the actual pattern of hypometabolism in the brain, and it's that pattern that you're looking for because it's different with different forms of neurodegenerative disease. So the individual's brain is compared to a database of normal brains, and the areas of difference are displayed in a colour scale of Z-scores or standard deviations of how much below the normal metabolism these areas of the brain are. So in the top line, we can see Alzheimer's disease with the typical reductions in the parietal and lateral temporal area, and on the medial views in that precuneus and posterior cingulate area. In logopenic aphasia variant of AD, it looks like AD, but it's mainly left-sided predominant. And there's also a bit of dorsal prefrontal reduction there. In dementia with Lewy bodies, again, it looks a bit like Alzheimer's disease, but you have occipital lobe reduction, both lateral and medial. In behavioural subtype of frontotemporal dementia, you can see the reductions in the frontal lobes, but also running up along the insula on those lateral views. And on the medial views, you can see there's also a reduction in the anterior cingulate and the anterior striatum in this person. In the progressive non-fluent aphasia subtype of frontotemporal dementia, you see reduction in the left prefrontal or dorsal prefrontal cortex. So it's taking out Broca's area, and that's why you get a non-fluent aphasia in this condition. In semantic dementia, the hypometabolism and atrophy is usually limited to the anterior left temporal lobe, though there is also a right hemisphere form of this type of dementia that usually presents with difficulty recognizing faces and other images rather than affecting speech. So FDG PET is useful, but it's not fantastic because hypometabolism directly reflects the degree of cognitive impairment. So in mild cognitive impairment, its sensitivity is much less than in Alzheimer's disease. It also becomes far harder to interpret in people over the age of 75. There's a lot of normal atrophy. There's often mixed disease, particularly a bit of vascular disease, but other conditions thrown in. And the typical patterns are not as well seen or as advanced in the more elderly population. And overall, compared to post-mortem diagnosis, it's got about sensitivity of 85% and a specificity of 70 to 80%. So we can do better by looking at the specific pathology of Alzheimer's disease. So we've now had amyloid imaging. We started doing this back in 2004 at the Austin Hospital for research, and we made it available as a clinical service in about 2015. Of course, in the United States, it's been available clinically, approved by the FDA since about 2012. So these are the patterns of amyloid distribution that you see on amyloid PET. You don't see this pattern in frontotemporal dementia. You do see it in about half of the patients with dementia with Lewy bodies because they do actually have amyloid plaques in about 50% of cases. This is how you read an amyloid PET scan. On the left, we have a negative scan. On the right, we have a positive scan. Now, these traces are a little bit sticky and they stick to the myelin in white matter. So in a normal study, you should just see a pattern that looks like the distribution of white matter in the brain. So you can see the white matter there with the fingers extending towards the cortex. But out in the cortical grey matter areas, there's no trace of binding. If you get a scan like this, it has a high negative predictive value for Alzheimer's disease. The scan on the right looks different, and that's because the grey matter where the amyloid plaques are sitting has bound the tracer. So now you've got this homogeneous uptake of white matter and grey matter, and you can see that the trace is going right to the edge of the brain, the frontal cortex there and the lateral temporal areas. And this dramatically increases your chance of having Alzheimer's disease when you have a positive scan like this. There have been 3 large post-mortem correlation studies done in over 200 subjects. So these are people that had an amyloid scan within 12 months of death, and then the report of the amyloid scan was compared to the report from the pathologist based on the presence of moderate or frequent neuritic plaques, which is one of the criteria required to make a diagnosis of Alzheimer's disease at post-mortem, and the sensitivity and specificity of the scans were over 90%. And since about 2014, it's been widely recommended that if you can get access to an amyloid scan or CSF analysis for Aβ42 and phospho-tau, in other words, these biomarkers for the actual pathophysiology of Alzheimer's disease, you can make earlier and more accurate diagnosis. So if you have someone with objective memory impairment and a positive biomarker, you can make the diagnosis of Alzheimer's disease. You don't have to wait for the dementia phase anymore, which is part of the traditional clinical criteria for Alzheimer's disease. Now, tau imaging is a more recent development. These are the first 10 patients we imaged who had a diagnosis of Alzheimer's disease and also had positive amyloid scans. You can see there's highly variable distribution of tau in the brain. There are these brightly coloured bits where the trace is stuck to tau. Generally, there's more tau in younger AD patients than in older AD patients, but it's usually there in both. And then occasionally you get some surprises, as we got in 2 of these patients. There was a 69-year-old gentleman with a mini-mental state of 24 and a surprisingly high degree of functional impairment. When he was tau negative, we went and had a closer look, and we found on his MRI he actually had bilateral posterior cerebellar infarction. He had atrial fibrillation, so these were probably embolic, and this is associated with a condition called cerebellar cognitive affective syndrome, where they not only have cognitive problems, but they have mood and apathy and depression symptoms. So that probably explains his problem, with a little bit of Alzheimer's pathology because he does have amyloid. On the far right was an 88-year-old with an amnestic type dementia, but tau negative, and when you look at her MRI, she has very severe hippocampal atrophy. So this would fit with late or TDP-43 encephalopathy. We can distinguish dementia with Lewy bodies from Alzheimer's disease by imaging dopamine transporters or vesicular monoamine transporters, as you can see here. Alzheimer's patients have a normal scan. You don't lose dopaminergic neurons in Alzheimer's disease, but in Parkinson's disease and dementia with Lewy bodies, there's a marked reduction in the dopaminergic innervation into the putamen, particularly the posterior putamen of the basal ganglia. So neuroimaging with PET can help determine the underlying pathology of a patient, clarifying the diagnosis and the prognosis, and direct the patient to the most appropriate therapy and to early intervention drug trials. I should also mention CSF is also available to help achieve this sort of outcome. And you can actually get CSF analysis done for Aβ42 and p-tau, phospho-tau and total tau at the National Dementia Diagnostic Laboratory at the Florey Institute of Neuroscience and Mental Health. There is a charge of about $350 to cover the cost of consumables and labour. Now I'm going to talk about the blood biomarkers. I'm particularly going to talk about the phospho-tau blood biomarkers because, as Michael said earlier in his talk, these are the closest to coming into clinical practice. They can be done on machinery that's generally fairly widely available, and the results are fairly robust. So the first report came out in about 2017. Then in 2018, we had an important paper coming up on phospho-tau 181. 2020, a very influential paper on phospho-tau 217. On the right, I've got a list of the publications that have come out over an 18-month period on these p-tau markers. It's an area of great productivity at the moment. We've looked at a tracer called phospho-tau 217 plus in collaboration with Janssen. They've developed this test and we've applied it to patients from the ABLE study and from the ADNet trial screening cohort. And you'll see here that in the cognitively unimpaired, or the normal subjects in blue, the level of this phospho-tau 217 doubles if you're amyloid positive, and it goes up about 3.5-fold if you have mild cognitive impairment or Alzheimer's disease, dementia due to Alzheimer's, so amyloid positive. It doesn't go up in amyloid negative conditions. So it's 85% accurate in detecting the presence of a positive amyloid scan. This is the raw data. These are the area under the curve. 0.89 is what we get. It's good for predicting tau as well, the same area under the curve for predicting a positive tau scan of 0.89. And if we look at all these area under the curves, because this is one way we can compare the tests, the performance of the various tests that have been done in this area. 0.89, as I said, for amyloid positive versus negative, or tau person versus negative. If you just look at those with cognitive impairment, MCI or dementia, it's still 0.89 for both, or 0.86 for tau. In the normal older subjects, amyloid positive versus negative, 0.84 for amyloid, 0.88 for tau. If you look at amyloid positive AD versus all cognitively normal, the area under the curve is 0.88. But if you compare it to the amyloid negative cognitive normal, it's about 0.94, which is really getting to be terrific. We also got 0.93 for dementia, amyloid positive versus negative, so very helpful for differential diagnosis of dementia. Of course, every test has a range, and you set the threshold where you want to in terms of sensitivity and specificity. So here's an example. This is showing the p-tau result in the entire population on the x-axis, and the probability they've got a positive amyloid scan on the y-axis. And you can see that if we're looking for a good positive predictive value, then we'll move the level up. And the 164 level there is 2 standard deviation mark of the amyloid negative cognitively unimpaired. There's a lower limit there for if we're looking in cognitively unimpaired and we want to exclude Alzheimer's disease. Any test is influenced by the prevalence of the disease. So if we look in the cognitively impaired group, where there's a 70% prevalence of disease, you can see that if we use that sort of middling threshold, our positive predictive value is terrific, 0.92. So you've basically made your diagnosis of Alzheimer's disease. But the negative predictive value was only 0.65, so it's missing quite a few subjects. In cognitively unimpaired, it's the opposite. The negative predictive value is terrific at 0.95, so it's certainly ruled out amyloid, but the positive predictive value is quite poor. So it's getting 50% false positives. For this reason, these tests should not be given to cognitively normal people unless they're specifically being screened for a trial and the positive results are going to be followed up for confirmation with a PET scan or a lumbar puncture. But I think future diagnostic practice will soon be influenced by these plasma assays, and this is my prediction. We'll do a clinical assessment, an MRI, and a plasma assay, and if it's positive, you've got your diagnosis of Alzheimer's disease. If it's negative, though, you're going to have to go on for further investigation. This may well be FDG PET, seeing there is a rebate for that, and this might show other pathologies such as FTD or dementia with Lewy bodies. You may want to get an amyloid PET. You may, if you're suspecting DLB, go for a dopamine transporter or VMAT imaging. In terms of what used to be future trial screening practice, it's actually become current trial screening practice. These blood biomarkers are being done as the first investigation now in screening people for drug trials. The Lilly trial that's going to be commencing soon is pre-screening with their 217 antibody. The AHEAD study, Eisai is a bit concerned that the positivity rate internationally is lower than they expected. They're going to bring in pre-screening with an A-beta 42 mass spectrometry measure that's done out of St. Louis, derived from Washington University and run by a private company called C2N. So there will be an amendment coming to the Eisai AHEAD study soon, which will include sending blood for pre-screening before you go to amyloid PET. So I'd like to thank my team at Austin Health, but also all the teams of ABLE and the ADNet groups. There's been a huge number of people that have contributed to this work. Thank you very much.
Thank you, Chris, for that presentation. There's one question that's come through on the chat line from Joseph. He says, noted the PVS allows for 3 FDG PETs across lifetime. When would you repeat this?
I don't think there's any point repeating an FDG PET unless once a patient's got a diagnosis, it's not a way to monitor disease progression because you do that clinically. So that's what I think Medicare was trying to avoid, people being sent along for annual FDG PETs to see how they're progressing, which is a waste of money. If you haven't made a diagnosis within 3 FDG PETs done a year apart, then I think you should give up, because obviously the diagnosis should have declared itself if they really had a neurodegenerative disease process by that time, if PET was going to show that process. So I think it's quite reasonable to limit it to 3 FDG PETs.
Thank you, Chris. And I think we're in the trials community, we're excited about these blood biomarkers reducing the number of screening PETs. I think that would be certainly a step forward. Do you see that as well?
Certainly for preclinical, it'll reduce the number of amyloid PETs by at least 50% that you need to do. It's not going to have such an effect in the MCI-AD group, because once you've screened somebody and you've proven they've got an amnestic objective problem, the amyloid positivity rate is usually about 70 to 80%. So you're not doing that many negative PETs for the MCI early AD trials, but certainly you are in the preclinical where 3/4 of the PETs are negative. So cutting that down would be a major advantage.
And lastly, I think Colin Mast's just saying that currently NDDL has run nearly 2,000 CSF tests during 2021, with about 30 to 50% positive for AD from across Australia.